for a nice introduction, and I'd like to say thank you to the organizers, Dr. Green and Dr. Ree, having me here. I certainly enjoyed the last couple of days with Dr. Rohr and looking at and understanding a little bit the greater Phoenix trauma system. So this is a little pet topic of mine, talking about polytrauma, the ultimate disease what a trauma specialists need to treat. So I'm gonna talk a little bit about some definitions and some clinical aspects of polytrauma. So this is where I'm from the east coast of Australia, Newcastle, and the hospital, as Tony mentioned, in the middle of a eucalyptus forest. So this is the country which is the size of the continental US and about 2 times bigger than the European Union, but we have only 22 million people in there, and most of us live at the coast. This is John Hunter Hospital in the middle of the forest, and the other foresty area is the University of Newcastle campus. So the outline is my talk. I'm going to mention that what is polytrauma and talk about the definitions and potential evidence, and why do we need to define this, and mention a few aspects of clinical care, research, and training. My tomorrow talk is going to be more clinical and mention many of the aspects of the clinical care. The 2 days one a little bit drier one. So polytrauma patients are the sickest of the sick who are we treating, and with any centers they have about over 10% mortality. And they have long-term consequences, and they require overarching specialist care and need specific resources. I used this slide in a session before where there was a interactive communication there, and how would you define polytrauma? And I think I included one of the questions for your CME, and I get all sorts of answers based on where people coming from and what sort of background they have. So the terminology of polytrauma in a Central European or German literature is a widely used concept during the last 30 years. In countries with English origin, and the United States so far was quite infrequently used, and usually was associated with those patients who have ISS over 15. And the synonyms used are a major trauma patient and multiple injured patient. And more recently, in the US military, started to use that. And if you look at the Wikipedia on the internet, the polytrauma definition is actually associated with the military definition. But it's not necessarily only the military patients. Actually, it's developed from the civilian practice. And many times what the Department of Veteran Affairs use is polytrauma centers, those centers who are rehabilitating these patients on the 5th level when they arrive back to the US. There's a big confusion in the literature. Here you can see one of the busiest European trauma center publishing in a paper, and in the title they use polytrauma, and in the methods they mention multitrauma. So the term is really can get confusing. So the main thing is, although the word multi and poly, depending whether you're using Latin or Greek, it means the same. But in the European literature, multitrauma means that more than one injury, but the effects of these injuries not more than the individual injuries. So basically these multitrauma patients follow the mathematics, and they usually don't have physiological derangement. Polytrauma involves more than one region, and these injuries just add up more than the individual region injuries. And they have altered physiology, and they have potential failure of the originally uninjured organs. So this is how these patients look like. As you see, this is what we see in the trauma bay, and this is what we have after the diagnosis or initial surgery. So where should I actually point? So these injuries require different priorities, and while individual injuries can be managed by a general surgeon, neurosurgeon, or an interventional radiologist, these add up together for a very complex disease what a traumatologist, an ultimate trauma specialist, is supposed to look after, not necessarily operate in all areas, but actually understand and guide the treatment, and know what's potentially behind these injuries, which may be occult and not obvious for subspecialists. So what we've done, I have a PhD student who picked this topic, and she done a systematic review and identified over 1,600 articles which mentioned the word polytrauma. And only 46 articles or book chapters identified with any definitions. So they will serve the further part of the review. And for these 46 articles, there were 8 different categories how to define polytrauma. So it's a big mess in the literature. But the main categories, as you can imagine, there are anatomical, physiological, and potentially combined categories. So what to do with the injury severity score? Can we use just ISS to define these patients? The problem is that if you look at ISS, whatever cutoff you use, and not necessarily all of them are polytrauma. You see here, somebody with a severe head injury, isolated head injury, can get ISS 25, life-threatening serious injury, but is something which can be managed by a neurosurgeon and a critical care specialist. It's not something which is with multi-system. The same thing for somebody have a isolated severe injury, maybe in the chest, and a few grazes elsewhere, and adds up ISS over 15, still not a polytrauma patient. And can get 25 from, again, relatively moderate injuries from other areas, which not necessarily causing physiological compromise. So these are just any day in our hospital runs 3 patients with all sorts of injuries. You can use the ISS. You can use whether they get massive transfusion, how many days they spend on the ICU, and what sort of approach you need. Probably the one we are looking at with relatively high ISS, long time on ICU, multiple system injuries, requiring major physiological input, and then have a coordinated approach. So can we use the new ISS for this definition? It was shown to be better predictor of mortality and MOF and multiple orthopedic trauma, but it's not really good for polytrauma definition because it ignores the different regions of the body. The most attractive definition coming from Switzerland, and a few publications follow that from there, which includes the tissue injury, the body response with the systemic inflammatory response, and the damage to the non-injured organs, the secondary multiple organ dysfunction or MOF. So should we use a combined anatomy and physiology score and use SIRS in addition to that? But the big question is when SIRS and how should we define that? And it should be a single measurement or persistent inflammatory response. So basically we found this in this review that there are some very good concepts, no consensus, and none of them were validated. And the best evidence was that something like level 3. So why is this definition is imperative? We think that subjectively we can define the patients who are thinking that the sickest one but we can't get these patients out from the registry. So if you run a search on your trauma registry or ISS 15s, probably 30–40% of those patients are real polytrauma patients only. And if you want to look at planning your trauma system and trauma center designation, those are the real ones which you really need to focus your resources. So what we done, we started to look at a little bit closer and try to get a higher level of evidence. So try to look at those patients who have at least 2 regions severely injured and see how do they score in terms of definition of polytrauma. In this study, what we done, we had based on the trauma surgeon's daily runs opinion, we said, okay, this is a patient who we think polytrauma, and look at that so-called gold standard compared to the different cutoffs. And what we identified that the highest percentage of polytrauma patients were in that group where we used ASS greater than 2 in 2 body regions. And these patients had a higher mortality rate, higher ICU admission rate, and more multiple organ failure. Interestingly, if you look at 2 regions with AIS over 2, then you have a highest positive and a negative predictive ratio and the highest kappa score in agreement with the polytrauma definition. So this is very easy to subtract from your trauma registry. And it's better than ISS 15 or 17 because you just pull out those patients with at least AIS 3 in 2 body regions, and they have 2 regions severely injured, potential threat for life, and all of them has some physiological derangement. So we look at the Zurich, Switzerland model, what to do with the SIRS if we include that, and we found that on admission we got good documentation of the SIRS, but it's really the initial vital signs, not the patient's inflammatory response. But when we look at later, these criteria for SIRS are not necessarily documented all the time, and you don't know when it should be present. And anyway, those patients who have 2 regions AIS greater than 2 in our observational prospective study, all of them get SIRS. So based on this, you can use only an anatomical score if you use the cutoff at the right level, because when you get to physiological scores, they're gonna get a much more noise in your data, especially comparing centers. So we put together an international consensus group with all the major societies represented around the world, and we had 3–4 meetings to get this hopefully right. And many of the group and or greater reference group has objections that, oh, why do we need this? We anyway know these patients. And does it matter how we call it? And we all agree who is the sick patients. So to address this, we've done a study which we are just about to just gonna be in press very soon. That how do clinicians agree on the definition? So basically, we here in a coffee break have a chat and discuss a patient and do we agree on that? So we had some 50-some trauma patients with a 1-page summary of their injuries, initial physiology, surgeries, and vital signs on admission to the ICU based on the first 24 hours, but there were no scores, nothing in there. And we used the inter-rater variability in the same institution and then internationally, and we looked back within 6 months, reassessing the same people, what is the intra-rater agreement in this. And you see that this is not very good. So if we work in the same institution, our kappa score gonna be 0.5, which is just something. But if we look here between Australia and Arizona, our agreement gonna be somewhere here, even lower. The problem is that if you look back yourself, this data, the agreement is not perfect still. So based on this, we need to have a consensus definition, how we define our sickest of the sick patient to make sure that you have something which is, can be comparable and can be benchmarked. What we started to use, even in our medical school curriculum, this is the question-based, what many of my students would like to have in advance, got this sort of concept introduced to them. So in summary, why do we need this? Clinically, we need a specialty identity. If you are an upper GI surgeon or a hepatobiliary surgeon, your disease to treat is pretty clear, or you are a pancreatic specialist, your disease to treat is pancreatic cancer. If you are a trauma surgeon, people think that, okay, you are just a kind of a generalist and you kind of do everything, but do you have a disease to treat? Well, polytrauma is the disease what you treat. This is the one what no other super specialist or single organ doctors can manage. So that's the disease, and you can identify in trauma center how many of these critical patients you have. In terms of research, it's very important to define this patient, because if you look at all the trials, big trauma trials, somehow whether we are talking about massive transfusion or whether we're talking about immune response to trauma or whatever, this is the sickest of the sick group what we want to have answers in critical care and trauma surgery. In training and experience, this is essential, because I think these are the cases what we need to log and count, because how many majors you see, they can be majors with a femur fracture and the next day signed off to the orthopedic service and not much to do with the overarching trauma care. But these polytrauma patients, what I highlighted there, this needs the highest level of decision making, and many things potentially can go wrong. And here, when we are potentially planning to improve or organize your system, where you put your resources is essential, because these are the patients which are going to suck up most of your clinical and monetary resources. So with this, thank you very much. And this is the place where I work and play, and most of my patients coming from these problems in a very, very safe environment. Thank you very much.